Thank you all the participants for joining us again today. Um, so as she mentioned, we heard about respiratory symptoms in palliative care last week. Gastrointestinal symptoms. Today we'll be hearing about respiratory symptoms and another important topic, that is delirium, which is very commonly seen in palliative care. Today we have two faculty. The first session is on respiratory issues in palliative care, taken by Dr. Rajam Iyer. Dr. Rajam is a pulmonologist and a palliative care consultant at Bhatia and Hinduja hospitals in Mumbai. She has done her diploma in palliative medicine, and she has also done her certificate course from TIPS Pallium India. She is one person who pioneered the clubbing of palliative care in pulmonology, especially in a corporate setting, and she's been as a faculty for many years right now. Thank you, Rajam, for taking this up. This is a group of medical college faculties joining us who will be teaching undergraduate students in their respective medical colleges in the future as a part of CPME program.
There's been a bit of a problem from my end. For some reason, my net is down. So I request Pallium India office to kind of upload this PowerPoint presentation they have. And I also request all the participants, you people do this regularly, teach the students. So please stop and make it more interesting by asking questions and interacting. Yes, perfect. Thank you for the PPT. And what we will, it's best if you all can, stop, ask questions, because it'll be a great learning experience for me also. So thank you very much for joining. I know it's a long weekend actually. So ideally, everybody would have been away on a break. Saturday, Sunday, Monday, and tomorrow being Independence Day. So let's start with this session. Like Sridevi said, I suppose you also have heard about palliative care scope in gastrointestinal system. I just wanted to continue. I mean, the next topic would be ideal to have how we can integrate palliative care in respiratory medicine. So can I have the next? So this is an important slide that as historically palliative care began for patients with cancers and those patients who were going to die with cancer. That means that dealing with a situation where historically everybody thought that if you have sent to palliative care, you should be dying of cancer. This is the slide that actually breaks that myth and actually explains
Rajam, your
to us
voice is a
that
little disturbed, not really clear. Maybe if you want, you can switch off the video.
I think it's all the Wi-Fi in the house.
Maybe
not able to hear.
It was breaking in between. Maybe you can switch off the video and try a little bit better.
Okay, let me see. I don't know what the issue is, and I hate it when such things happen. Okay, now is it better?
Yes, yes.
Can you hear me?
Yes, I can hear. Shripriya, it's audible, right?
Not that stable as so maybe I can stop the video from my end once and check.
I don't know if that will change.
Medicine at Bharti Hospital, Pune, in the Department of Critical Care Medicine. She has done her MD in palliative medicine from Tata Memorial Hospital in Mumbai, and she's currently working in Pune. She's been with us as faculty for some time now. Thank you so much, Rutula, for joining. And these are all faculty members from medical colleges across the country. And this is a part of integrating palliative care into undergraduate medical education. So, over to you.
Thank you so much for having me back. So I'll just share my screen and then we'll start off. Can you see my screen?
Yes.
Yeah, okay. So we'll be discussing delirium today. If you have any queries, if you have any suggestions to give, please feel free to interrupt me in the middle and then just ask those questions. The topics that we'll be covering would be the definition, risk factors, assessment of delirium, management, and just in brief about what terminal delirium is. So coming to the definition, just give me a minute. Yeah. Okay, so coming to the definition, so according to the DSM, the core features in delirium would be disturbances in the consciousness with reduced ability to focus, sustain, or shift attention. So basically, what it means is that there is lack of the attention span has reduced, and there is inability to maintain any sort of you know order in which the person is doing various activities in the daily routine. Then there is change in cognition or development or perceptual disturbances, not anyway explained by an pre-existing condition or an evolving dementia. So there might be some problem with the mentation, or there might be some memory loss as well. Then these disturbances generally are very acute in nature, so they develop over a very short period of time, in days to maximum of a week. So it's within a week or week span that it develops over. And it keeps on fluctuating throughout the day. So most of the time, the symptoms are worse in the evening. That is also called as sundowning effect. So they keep fluctuating throughout the day as well. And there is evidence from the history, the examination, and the laboratory findings that will indicate whether it is a direct physiologic consequence of a medical condition, and maybe like an intoxicating substance or medication use, or there might be multiple causes as well. So in short, to define it, delirium would be an acute confusional state, which is a common syndrome, which is usually characterized by a disturbed consciousness, cognitive function, or perception, which has an acute onset and fluctuating nature. So what are the different reasons? Basically, coming to the physiology of it, you have everything that is involved in, or rather all the neurotransmitters possible. Basically, activation or inhibition of all of them would cause delirium. So it can be cholinergic system, it can be GABAergic system, glutamate, cortisol, serotonergic, melatonin deficiency. There might be inflammatory response because of an inflammatory response, or dopaminergic as well. So coming to the types of delirium, so it's basically hyperactive delirium, hypoactive delirium, or a mixed type of delirium. Hyperactive delirium is the one which is most commonly noticed by everyone, where the patient is agitated and restless and maybe sometimes aggressive. So it's basically a heightened arousal state of the patient. In hypoactive, it is the opposite of that. So it's basically the patient is very quiet, maybe sleeping most of the time and withdrawn. So there's not much response to that. So sometimes it might just go unnoticed if the patient has hypoactive delirium. And mixed is the one where there might be sometimes an hypoactive element which is predominant, or sometimes it is the hyperactive phase which is predominant. So coming to the risk factors, so the common risk factors would be old age. Constipation in old age people would be another very common risk factors. Medications. Can anyone tell me what are the common medications which would lead to delirium? Just you can type in the chat box. I'll just open my chat box as well. Okay, quinolones.
Yeah,
Anything else? Anything else?
Atropine is another response.
Yeah, atropine. Very good. pregabalin, benzodiazepine. Yes. Yes, alcohol. Yes, very, very common. Steroids. Amitriptyline. Yes. Okay, great. So, these are few of the medications. Then sometimes even, basically any intoxicating medications would lead to, would be an potential reason for delirium. So even opioids sometimes might result in deliriums, if especially if any other risk factors are associated with it. Yes, so steroid overdose or steroids, when would they be, when would the patient be at particular risk of getting delirium because of any steroid? Any guesses? So generally, your natural or rather inherent cortisol circadian rhythm has to be monitored when you give steroid externally. So usually what happens is that the steroid levels or the cortisol levels are generally high during the day and they kind of dip during the evening time. So in case the patient is currently on a high dose or high dose regime of steroid and you give it in the evening, what sometimes happens is that the patient, the cortisol circadian rhythm gets disturbed, because of which there is kind of initially starts off with insomnia in many of the patients, and I've seen this personally also. So it initially starts off with insomnia and gradually develops into a frank delirium, and most of the time it is hyperactive delirium that the patients land up in. So make sure that whenever, even if you're giving like a tedious dose of dexamethasone, make sure that it is before, let's say 4:30, maximum of 5 o'clock in the evening. So you give that before that so that it does not kind of, affect the natural rhythm of the cortisols in the body. So yes, steroids. So various infections, especially CNS infections, would lead to, would be a risk factor for developing delirium. You have your dyslipidemia. So almost all of them would cause some sort of delirious episodes in the patients. Brain metastasis, stroke, or encephalopathy. So anything that is affecting the brain parenchyma would lead to delirium. You have your toxins, nutrition deficiencies, sometimes even severe pain may lead to delirious episodes. Post-surgery or ICU stay are the patients are at high risk of landing up with delirium, especially when if they are, they have any other risk factors associated with it. And prolonged immobility would also sometimes lead to delirium. So basically what they said was that prevention, as for every other pathology as well, so prevention of delirium is always better than managing delirium. So there was a study in which the patients were divided into two arms, in the sense that one arm got the preventive measures for delirium, such as orientation therapies, maintaining their activity and mobilities. They had good sleep pattern. They were provided with good sensory aids, for example, hearing aids or glasses, and it was made sure that they were not dehydrated and all that. So it was seen that many of the patients responded well or had lower risk, lower delirious episodes than the patients who were not given all these therapies. So in any patients who are especially with chronic diseases, it's always better to prevent the episode of delirium rather than treat it, because delirium is one of the morbidity indicators or mortality indicators, is a direct indicator of mortality. So, and the prognosis worsens with each episode of delirium. So it's kind of better to prevent delirium rather than treat it. So as I said before, they had fewer episodes of delirium, and even if they had delirium, it was for a shorter duration. And there was also risk reduction in these patients. Then coming to assessment, so mini mental state examination or Montreal mental state examination would be the screening tools. Diagnostic would be your CAM or delirium rating scale or memorial delirium assessment skills. These are available freely on on the net, so you can just maybe print it out on and kind of have a look at like assess patients whenever required according to that chart. Then coming to the management, so basically if there as I said, it's an acute state of confusion. So, and usually has some sort of underlying pathology because of which it is occurring. So, if there is a treatable cause, always treat it first and then try to manage the symptoms that are present in the patient. So treat the cause, ensure that the patient is safe, especially in the case of hyperactive delirium where the patient is very restless and agitated, sometimes even aggressive. Then it should be a safe environment for the patient and the caretakers as well. And obviously, the management is based on the reversibility of the situation and what are the goals of care for that patient. Potential reversibility means that the delirium would be reversed if the underlying cause is treated. So that is the reversibility part of it. Irreversible delirium usually is equivalent to terminal delirium, where even despite managing all the possible and potential reasons for the delirious episode, it is not responding. So that would be a irreversible delirium, or also known as terminal delirium. Then, so basically is, as I said, reversible, irreversible. Irreversible would be in a dying patient if the treatment is not successful, or if the goals of care of the patient are no further treatment. So those are the irreversible causes, and potentially reversible causes would be all the rest that we just saw, those infections, toxins, drugs, and all those. So those are the list of reversible causes. So for that, basically, you need to have some workup done. You should consider the risks and benefits of the treatment, and always go for a time limited trial just to see if the patient is responding to the treatment, and what are the outcomes of the whole management plan. So as always, first non-pharmacological management and then pharmacological management. So in non-pharmacological management, you provide them with all the possible sensory aids so that there is no loss of, let's say, hearing or vision, because of which might be a potential reason for the delirium. So provide them with good sensory aids. Maintain a good sleep hygiene. So sleep hygiene includes your wake time, sleep time. That should be sort of fixed, or a routine should be made. Then there should not be frequent disturbances when the patient is sleeping. Maybe certain regime before going to sleep so that they get into habit of doing that. So it becomes like a fixed pattern in which the whole sleep is managed. So that is included in sleep hygiene. Then orientation with the help of either a big clock in front of them, which tells the time clearly, and the numbers on the clock are also very visible and easy to read. So it should be 1, 2, 3, 4 instead of the Roman alphabets, which can be sometimes confusing. And it should have all the hands of the clock as well, which are visible from their bed. Then you should have a calendar with visible or legible dates and days so that they know what time it is, what date it is rather. Then there should be natural daylight. So you should avoid closing the curtains in the day and putting on, tube lights or bulbs, so that they know that it is daytime and when it is evening. Curtain should be open for natural sunlight to come in. So they have an orientation of day and night as well. During the nighttime, when you need to switch on the lights, make sure that it is a bit dim so that they don't get confused because of the visual receptors where they feel that it is daytime even in the evening. And the family members or the caretakers as well, they should be a constant. So it should not be that every day someone else is coming to take care of them. It should be one constant person so that there is minimal confusion in the care for the patient. And even the caretakers in the hospital, like the hospital team, if the patient is admitted, they should remain the same. So one or maximum of 2 nurses are going to manage such patients. There is not frequent disturbing of the patient. Like they shouldn't go in every 2 hours to take the blood pressure or the temperature on of that. It should be minimized to the bare minimum that is required. And also the room that is provided to the patient should be in a quiet environment with minimal external noises so as not to disturb the patient any further. And if possible, if it's in the hospital, or if it's at home, then well enough. But if it's in the hospital, if it is possible to get some familiar objects for the patient to be kept in the room so that they know that it is all their things and he or she is in a safe environment. Then, as I said, daily routine should be fixed. There should be some sort of movement and physical activity. Any sort of cognitive exercises are advised or promoted. Some leisure activities in which they're just reading, maybe, or relaxing techniques that they enjoy, so as to take their mind off any stressors. Then you should limit the immobilization because of various things such as catheters or restraints, etc. And aromatherapy, plus minus, like it works for some, it might not work for others. So as and when you find it helpful, and if you have someone who is an expert in giving such therapies, then that is also advised. Then coming to the management, so as of now, it's not like no medication has been completely approved for delirium. You have many medications which manage the symptoms of delirium, but according to study by Agar et al., so they basically said that non-pharmacological measures are better or rather equal in managing delirium as the pharmacological counterparts, and both given together have a better result in reducing the risk for developing another episode of delirium as well. So non-pharmacological measures for managing delirium would be more important than the pharmacological counterpart. So as I said, it can be either hyperactive or hypoactive delirium. So if it's an hyperactive delirium, you basically will have to treat them with antipsychotics. So because the symptoms usually are agitation, hyperarousal, disorganized thinking, hallucinations, and sleep disturbances. So basically, you need some medications to manage all these symptoms so that they are comfortable. So basically, the agitation and hyperarousal would be your sympathetic activity. So for that, you would have to give an alpha agonist. For all of these, antipsychotics would be helpful. For your sleep disturbances, melatonin can be sometimes used to manage or regulate the sleep cycle. So coming to the antipsychotics, so basically here we generally commonly use haloperidol, risperidone, olanzapine, and quetiapine. And chlorpromazine also. So haloperidol will have anti-agitation, but not so much of a sedative property. if you want sedative property, the commonly used ones are olanzapine and quetiapine, because you can manage the dose very easily here. Then coming to the benzodiazepines, they have amnesic property as well. So these can be used, especially when the patient has a lot of hallucinations. Benzodiazepines can be used if there are a lot of hallucination. But what happens is that sometimes because of this amnesic property, the delirium might worsen as well. So you need to kind of manage, or rather assess the risks and the benefits of giving benzodiazepines. Benzodiazepine should never be given as first line for managing a potentially reversible episode of delirium. They can be used to sort of sedate a very aggressive patient, but they should not be given as a treatment for managing delirium. So because it sometimes worsens the symptoms and worsens or prolongs the delirious episodes. So it can be given as a start dose for just to kind of calm the patient down, to get him not be so aggressive, but not as a continuous oral or injectable formulation. So basically, if it is a reversible hyperactive delirium, first line is never benzodiazepines. First line would be your antipsychotics. Then initiate your reorientation techniques as well. So they go hand in hand, right? Then agitation can be treated as a breakthrough symptom. So as and when there is an episode of agitation, you can give SOS doses of antipsychotics, and on a regular maintenance dose of antipsychotics as it's ongoing. Then coming to haloperidol. So basically for delirium, you'll generally start off with 2 milligrams and can be escalated up to 10 milligrams per day as well. Usually you start off with an HS dose, but you can divide it in twice a day dosing also if you are going up on the dose. The risk is it has a potential for prolonging the QT interval and Parkinsonism as well. But you'll have to weigh in the risks and the benefits of it. So basically you'll have to see if especially if the patient already has some cardiac issue, then maybe it is better to avoid haloperidol and go for maybe quetiapine or olanzapine instead. But you'll have to kind of manage, weigh in the risks and the benefits of the medication. So basically, risk of adverse effects. So extrapyramidal is mostly seen in haloperidol, and sedation is best in chlorpromazine, and QT prolongation is maximum by chlorpromazine, but the risk is present all through the board. So those. So alpha agonists, so these are actually excellent for managing agitation and hyperarousal. These are generally used in the ICU for sedative purposes, and they are sometimes even preferred over benzos and opioids as well. So Dexmed is the most commonly used, and so since I've been working in Bharati Hospital, I've had a lot of patients in the ICU who have been given Dexmed, and sometimes they also help with the restlessness caused because of breathlessness as well. So it kind of helps you, if the patient is having a lot of tachypnea, that also sort of reduces with Dexmed. So it is kind of helpful in that sense as well. And it is the dose can be monitored through over a period of time and increase and decrease according to the needs of the patient as well. So these are good. Clonidine will have to be monitored more carefully than Dexmed. but that can also be used. Melatonin basically helps you to kind of synchronize or regulate the sleep circadian rhythm. So, and it has shown to help patients with chronic insomnia or chronic disturbances in sleep cycle. Usually you start off with a dose of 3 milligrams HS dosing. So it needs to be given at least 2 to 3 hours before you go off to sleep. So if you're going to sleep at around 10 o'clock, then it needs to be given at around 7 to 8 o'clock in the evening. So it kind of needs to be given around that time, and not many side effects that are associated with it. So it's pretty safe to be given for patients. So basically, as I told you already, this study basically showed that your orientation methods are better than your medications, and also help prevent further episodes of delirium. So these are good at managing the symptoms of delirium, but reorientation methods are the ones which are actually a lot more beneficial in treating the episode. So yeah, that was the thing. So basically it was inconclusive. So basically placebo was almost equal to medication. So reorientation methods are equally beneficial. These are the studies. So good nursing care, non-pharmacological measures, treating the underlying cause, using antipsychotics as and when needed, starting with the lowest dose and titrating it up. And if there is severe agitation and aggressive patient, then giving benzodiazepines if needed. Otherwise, best to avoid it because it can sometimes worsen the episode of delirium. Then coming to terminal delirium. So if it is irreversible, as I said, the patient is either dying, the treatment is unsuccessful, and or the goals of care of the patients and the family relatives are fixed, then it is a irreversible cause. So basically, this is just an example or case for delirium. Let's manage that. Just give me a minute. I can't see the case. Yeah. So it's an 85-year-old male patient with end-stage cardiac failure. And he's admitted in the hospice with worsening pain, dyspnea. Was on scheduled morphine which had some relief. Now there is irregular breathing, audible secretions, cold, clammy skin, molting of extremities. He's extremely restless, agitated, picking at the bed sheets, moaning. The dose of morphine was increased with improvement, without any improvement, and the patient became more agitated. Now, what would be the potential from the history? What would be the potential reason for agitation and restlessness? In just maybe in the chat box. What from this case history, what are the reasons for increased restlessness? The pain, yes. Anything else? What are the other symptoms that the patient is having? Breathlessness and hypoxemia, metabolic derangement, maybe, yes. And there are secretions like audible secretions. So there's a lot of distress breathing in. So do you think that this patient is dying? Do you think that the patient is actively dying? HIE, okay. We'll need some more investigations for that maybe. Do you feel that he is actively dying? Do you have any signs or symptoms which are pointing towards imminent dying or death? Renal encephalopathy. We don't have enough history to label it as that, but maybe, yeah, I'm sure that can be possible. So the signs, there are signs of neurological failure. There is altered level of consciousness, abnormal breathing pattern. These are signs of actively dying. All right. So not related to the case, is just the signs of active dying process. There is loss of swallowing or gag reflex. There are a lot of tracheal or oral secretions. Delirium may or may not be present. Loss of sphincter control. Then you have your cardiac failure signs. You have your tachycardia, venous pooling, cyanosis sometimes, peripheral cooling, and renal failure, which is oliguria or anuria. So coming back to the case, do we have any signs of active dying here? So there is irregular breathing. We don't know what pattern exactly, but there is irregular breathing. We have audible secretions. There is cool skin. So most probably peripheral cooling is there. Molting of the extremity is also there. So this seems to be the few signs of actively dying. We'll need few more investigations or maybe history to know if there are any other signs present, but it seems as though that patient is actively dying. So coming down to the two roads of death in delirium patients would be that the patient is sick, he gets sleepy, lethargic, obtunded, semi-comatose, comatose, and then he dies. So this is what would be the hypoactive delirium. Usually this is what happens when the patient deteriorates, and the patient dies. So you won't have to do many things for this patient. Usually it's a very peaceful death, unless there are hallucinations in hypoactive delirium as well. Then it might be very distressful, but it is difficult to know if the patient is having any hallucinations in hypoactive delirium. Now, the other road to death would be the patient is sick, becomes very restless, confused, starts hallucinating, is tremulous, keeps on mumbling something, may or may not have some myoclonic jerks or seizures. Then he becomes comatose, and he dies. So this is very difficult, very distressing, not only to the patients, but also to the caretakers and the family members who are seeing him suffer through all this. So that is a very difficult road towards death. Now, coming to the difficult road of irreversible delirium. So what, especially hyperactive ones. So what basically we need to do is we need to support them. We need to treat the experience. So here you would give benzodiazepines or any sedatives, because you are not potentially trying to reverse the episode of delirium. So here the first line would be benzodiazepines, barbiturates, or propofol if benzos are not working. So here you would give either Loraz or midazolam, whichever is preferred, because it has all the potential things that we want to manage. So it will have anti-agitation, anxiolytic, sedative property. It will have amnestic properties. You have your muscle relaxants, and also your anticonvulsants as well. I'm sorry, this just got, yeah. Anticonvulsant property as well. So here you need all these benefits of the benzodiazepines to manage this, because it's irreversible. You're not trying to reverse the cause. And as you can see, antipsychotics and opioids may not have all these properties. So benzos are preferred over both of them. So if it's irreversible cause, Loraz can be started as 1 to 2 milligrams orally or sublingually every 60 minutes PRN dose, with every 6 minutes PRN doses as and when required. Or it can be given as a subcut injection as well. If it's not responding, then you might have to step it up, or you might need to add in another medications as well. Coming to the hypoactive delirium, even if it's potentially reversible or irreversible, the thing is that many of the times we'll not even realize that the patient is having an episode of hypoactive delirium, because usually they are very calm and quiet and sleeping most of the time, and no one wants to disturb these patients, right? Like no one wants to go and wake them up and potentially hear a lot of problems. So usually it is ignored. But as I said, sometimes if the patient with hypoactive delirium is going through is suffering from hallucinations or paranoia, or there is a lot of disorientation, then you might need to give antipsychotics if required. If it is a reversible cause of delirium, then you need to kind of treat the cause, manage the medications accordingly, lower the doses of certain medications or increase the doses of certain medications, whatever is required to manage. Usually, I have seen hypoactive delirium in patients with hypercalcemia, because most of the time they kind of are sleeping many of the times. Sometimes they are with hyperactive delirium, but many of the times they are with hypoactive as well. So you need to kind of have a very stringent lookout for hypoactive delirium, especially because hyperactive you will spot just like that. It's the hypoactive ones that you need to look out for. So basically, to manage that. And then again, so you basically, if it's irreversible, then if there is no hallucination, there is no need to treat it. But if there is any hallucination or any distressing symptoms, then you start off with benzodiazepines or antipsychotics, whichever is preferred. That's it. Thank you. Any questions or?
Thank you, Rutula. We'll take a few questions if there are any. Participants, you can either type it in the chat or can unmute and ask if there are any questions, both from respiratory symptoms and delirium. Can't see any questions.
When the patient is delirious, is it worth taking such a patient to a hospital or a tertiary care center, or we manage the patient at home?
So it again depends if it is a reversible cause is there for the delirium. If it's reversible, then it would be worthwhile to take the patient to the hospital, get him or her investigated, treat the cause, and manage the episode. But if again, if it's irreversible in the sense that the goals of care are set in, like you don't want to go any aggressive, you don't want to do anything further, then it might as well be managed at home with antipsychotics or benzodiazepines as whatever is required. So it depends on.
Yeah.
Sorry.
If there are any signs of death, impending death, like we know this cooling of the skin and breathing and all that stuff, so better to manage with whatever we can at home, right?
Yes, that is
Instead of,
perfectly fine. Yeah, that is also
instead of
fine.
manipulations and intubations and whatnot, like in the hospital.
Yeah. So again, so basically what needs to be done is that at least the emergency department needs to be sensitized about chronic diseases and the potential of them of the whole episode, of whatever reason they're coming to the EMD being an irreversible cause. So they need to be sensitized about that as well. So their threshold for intubating and shifting such patients to the ICU becomes very high, so that they kind of they kind of themselves screen the patients whether they should be shifted to the ICU or not.
Okay. So it's better to take the family into confidence also and explain to them the situation.
And it's always better if you document the DNR status, or do not escalate, or do not shift to ICU on some formalized form of for the institute, and keep it
Okay.
attached to the file, so that every time they come to the hospital, they have that as the first page. So all the EMD doctors will also read that. So they have like a documented paper. So it becomes easy for them also.
Okay, okay. Sometimes it's the patient's will, no? Like the wish.
Yeah. Again, it's according to the wish. So if the patient or the relatives are insisting that they want to get admitted, they want to be shifted to the ICU, there's not much you can do. You will
No.
have to shift them.
Okay.
So again,
Yeah.
previously, if you've had like a good counseling session or good communication with the family and the patient, then that kind of becomes set in. Like your goals of care are fixed. So
Okay.
documenting that, keeping that in the file. So it reduces the patient and the caregiver distress as well with
Okay.
every hospital visit. So
Thank you.
that's good to have.
And we have another session tomorrow, day after tomorrow, on end of life care. So probably Dr. Sangamitra will be talking about anticipatory prescriptions as like when we identify that the patient is dying, and then sometimes we do give anticipatory prescriptions if terminally, if there is agitation, this medicine to be given, etc. So we can write and prepare and give the family.
Yeah, okay.
And maybe it's always a good idea if you can identify like a local physician for that patient. So local physician in the sense like maybe 5-10 minutes walking distance from the house, so that in case there is an emergency, that doctor can come in and have a look. So
Okay. A family physician type.
yeah, family physician type. Yeah.
Okay. And the death certificate will be given by the family physician or by the...
So they can give it, but in my experience, usually it's like if they have been seeing the patient over years, then it is easier for them to give that certification. But if they've not, then they usually ask them to go to the parent institute. So however it is in your area, that's how it is.
Thanks for the lovely session on delirium, because it made many of the these facts clear. So thank you.
Thank you.
There are two questions about role of SSRIs in post-operative care and dose of morphine.
I didn't get the first question. Role of SSRIs in post-op care, as in if the patient is having delirium, or for neuropathic pain, or for what? Like what exactly do you mean by that?
I think
Is
for
delirium?
delirium.
Okay. So basically, if the patient is having delirium, so post-op also there might be many reasons as to why the patient is having that delirious episode. So it's always better to identify the underlying cause, manage that well, and then give SOS requirement of SSRIs or any other antipsychotics which are needed. So, but I would still prefer either olanzapine or haloperidol, or maybe quetiapine over SSRIs. So whichever. Yeah. And but yes, whenever required, you can give that.
There is a question on dose of morphine. Dr. Shaida, the question is not clear. Are you asking managing delirium when patient is on morphine, and how do we need to regulate the dose, or is it dose related? Is that what you're asking?
During acute delirium. So if the patient has been on morphine for a long period of time, delirious episodes are generally not that often seen because of morphine. So you might as well continue the morphine dose or escalate it if required. If the patient has just been started on morphine and suddenly has a delirious episode, it might be kind of attributed to the morphine dose or morphine drug itself. So in that case, it might be a good idea to maybe reduce the dose or stop the drug completely, switch over to some other medications if possible. and manage the delirious episode and maybe reintroduce morphine if that is the only available opioid with you, or maybe switch over to maybe fentanyl or buprenorphine also. So in that case, so usually long time users of morphine for pain won't have a delirious episode because of morphine. The newly started ones might develop. In that case, it's a good idea to withhold the drug for a few days at least and slowly reintroduce it later on, or switch over to some other opioid. I would like to know the nicotine patches in post-op care to manage withdrawal effects after near total laryngectomy. So they come in 3 doses, if I'm not mistaken. It's I'm not sure of what the doses are. Wait, 6, 12, 24. I think that's what the doses of nicotine patches are. And they are applied every 24 hours. So you have to change the patch every day. 12, 14, 21. Okay, 7, 14, 21. Okay. So you need to kind of calculate the dose based on how much they were smoking, like how many cigarettes per day they were smoking. And you need to, it needs to be done, and I would say it needs to be done under psychiatric guidance, psychiatric evaluation and guidance, because I've tried to manage, or rather it was for smoking cessation, basically not a post-op care. I've tried to manage it according to what they've said on the pamphlet and what I read through many articles. It did not seem to work that well. So I think they need the CBT or counseling part of it as well, along with the patches. So only patches won't work. But if you're just trying to manage the withdrawal symptoms of it, then you need to calculate the dose of the patch according to how many cigarettes or BDs they were taking per day. So that dose needs to be calculated, and then yeah, so basically the delirium in such patients would be because of the withdrawal symptoms, right? So it would be the withdrawal of nicotine that is causing the delirium. So patches would help with that. So, but you still need to, I would still say that, you know, just putting them on patches sometimes may not work. And sometimes the patients are smart enough to apply excess of patches just to get that high. So it's better to do it under psych evaluation and psychiatric guidance, just to get that reinforcement on use of patches and slowly withdrawing of the patches as well. Yes, yeah, they become, because they don't have that urge to smoke now. So what had happened with my patient was that he had drastically come down on the number of cigarettes that he was taking, but he was not able to kind of completely stop those last 4 cigarettes that he was smoking. So according to that, I'd put him on a 7 wala patch, and he, despite taking applying that patch, he would smoke those 4 cigarettes. So then I realized that, you know, though they put in that patch, they just take that thing, you know, just take the smoke because they are used to it and they get that high. So patches won't give you that high. So that's the reason. So to just kind of reinforce everything, it's better to do it under guidance.
Maybe if there are no more questions, we can wind up today's session. Thank you so much, all the participants, for being with us. And thank you so much, Rutula. And Rajam could not join, but Rajam was there. So if you have any queries in respiratory symptoms, we are happy to answer your queries through the chats. Thank you so much, everyone. Over to you, Supriya.
Thank you, Dr. Rutula, for joining in. Thank you all the participants for making the session interactive. We do have one more session in the basics module, which will be covered on 16th. Tomorrow is public holiday, so we will not be having sessions. Enjoy your freedom and happy Independence Day to all. See you day after tomorrow. And till that time, this is Sri Priya along with Dr. Rutula and Dr. Srideva. You're signing off from the Deep Psycho. See you in the next session. Till then, everyone, take care. Bye bye.
Bye.